Okay, let me know when you're ready.
Okay. Hello, everybody. This is Jackie Drew, and I'm the president of the WCPT Oncology, Hospice and Palliative Care, and HIV/AIDS Association that's developing into a subgroup within the WCPT. And today we're very pleased to have Carrie-Ann Wood and Rebecca Mullin, who are physios from London, England, and they're going to be presenting on adherence to exercise. I just wanted to make a comment that this is being recorded so that if people want to come back and watch it again or share it with a friend, the recording link will be available on the WCPT Oncology, HIV/AIDS, and Hospice and Palliative Care website. So without further ado, Carrie-Ann and Rebecca, I will turn the microphone over to you.
Brilliant. Thanks, Jackie. Thanks, Jackie. Okay, so thanks. Oh, we got it now. Yeah, we good to go? Yeah, I think so. Okay, well, thanks, Jackie, for inviting us to speak today. We think it's such an excellent platform to share what we do, and hopefully by the end of it, if there's other people who want to engage in a conversation at the end, it'd be really good for us to meet other people who are interested in HIV research in the field of physio too. We personally have been really excited about this event and sharing our findings, so I really hope you enjoy what we have to say. So, oh lovely, thanks. Oh, it's not working. Okay, so just first about me, my name is Rebecca Mullin. If you've read the bio, then you've probably got a lot of this information already, but in case you haven't, I'm a clinical and research physiotherapist who is working at Guy's and St Thomas's and has done for the last 7 years. My background is working in complex neurorehabilitation and HIV, and I've gradually progressed in my career, narrowing my sphere of focus down towards more complex neurorehabilitation in this area. I worked as the highly specialised HIV physio at St Thomas's between 2010 and 2013. And in September of last year, I went on a research sabbatical to complete a Masters of Clinical Research project. And I've recently returned to the hospital in a slightly different role, and that's where Carrie's come in.
Yes, so my name is Carrie-Ann Wood, and I came back from maternity leave while Rebecca was off doing her Masters of Research. So I'm now specialising in neurology rehab and HIV rehab. Have a background of working quite a lot with complex rehab, mostly in acute elderly care. And as you might hear from my accent, my very gentle accent, I qualified in South Africa, and that was 10 years ago now. And I spent a year working in a very rural setting in South Africa, and saw quite a lot of patients at the end of their fight with HIV. And actually, it's so nice to come back 10 years later and see how things have changed and progressed over that time. So it's really exciting field to be involved in at the moment. Okay, so we're just going to take you through what we're hoping to achieve with you guys today. I'm going to go through helping you again.
We had
Sorry, okay, I'll just keep talking. We would like to help you gain a basic understanding of HIV as a disease and put it in a global setting. Overview of what we do in terms of HIV-specific physio services that we run at our hospital, which is Guy's and St Thomas's. And then I'm going to hand over to the lovely Rebecca to describe the research study that she's completed within our team, looking obviously at adherence behaviours of HIV. And then we want to look at promoting discussion regarding how we can use this information from the study to inform our clinical practice. So I'm just going to let you look at the screen for a couple of minutes. It's full of terms that are commonly used in the field of HIV. I'd like to just draw your attention mostly to the HAART, which is highly active antiretroviral treatment, which is the medication that people with HIV are given, and the fact that we rather use the term advanced HIV nowadays instead of AIDS. If you just absorb those, and if you have any questions, then you can always give us a shout. Okay, so let's just talk a little bit about what HIV actually is. So HIV stands for the Human Immune Deficiency Virus, and the clue is pretty much there in the name. It's a virus that affects humans. It attacks your immune system and makes it deficient, which means that it's less able to protect you. It's a retrovirus, meaning it needs a host cell, and the host cell that it chooses is the CD4 cells, which are part of your white blood cells, and they have the main role of sending signals to cause destruction of infectious particles. So how the retrovirus actually works is it inserts a DNA copy of its genome into a CD4 cell, which then destroys that cell, and it becomes a virus factory which produces other copies of the virus that then infect other CD4 cells. So it breaks down all your CD4 counts and then basically makes you more at risk of opportunistic infections and also, unfortunately, cancer. Let's look at it globally. So here's a map. The stats from the World Health Organization. So this is the most up-to-date that we have at the moment, which is, it is 2 years ago now, it's for the whole of 2012. You can see there's a global prevalence of 0.8%, which means that it's about 8 per 1,000 members of the population are infected with HIV. And the darker colors are the higher areas of prevalence. And so you can see that sub-Saharan Africa is still the main area of prevalence. And to put that in context, out of the 35.3 million people worldwide with HIV at the end of 2012, 71% of those people came from sub-Saharan Africa. And in 2012, 1.6 million people died of advanced HIV-related illnesses. So it is a pretty big deal. It is growing, and the testing is improving, so we're more aware of it as well. In terms of looking a little bit closer to home for us in England, there are around 156,000 people in England who access care in the UK. And we're very lucky here that we actually have free comprehensive healthcare for HIV available through the NHS. More than 45,000 people of the 156,000 with HIV are living in London, and that's around a third of the nation's total. So it's a really high prevalence area. Overall, the rate of transmission is decreasing as we are increasing our testing and screening. So in all hospitals that are NHS hospitals in the UK, all A&E patients are tested, and all women who are under antenatal care are tested as well. And in 2012, there were 6,360 new HIV diagnoses in the UK. So why is St Thomas's Hospital running HIV services? Well, London is one of the highest prevalence areas in the UK, as you can see from that previous map. We have 10 to 13 per 1,000 population in our 2 local boroughs. London also has a number of specialist HIV services, and I think it's twofold. If people come from further afield to access these specialist services, but people also come from further away because there is unfortunately still a stigma around having HIV. And then we obviously serve the local boroughs as well. In terms of what we're actually doing, if you run a specialist physiotherapy exercise advice clinic, we also run a joint metabolic clinic with a dietitian, which works with one of the HIV consultants and is around lifestyle advice and exercise advice and diet management. And then we run the gym group, which is really what this is all about today. So there's a picture. That's what we can see from our lovely hospital, the Houses of Parliament. We're very lucky, except actually we work in a windowless room. But if you were to go outside, that's what you'd see. The HIV gym group has been running at our hospital for 10 years now. It is only twice a week. It's a 1-hour session, but it is a 10-week exercise program. So each patient who comes through should be doing at least 20 supervised sessions of exercise. Ideally, we'd love that to be more, but logistically, in terms of the staffing and the availability of gym space, we can only really offer it twice a week. Our aim is to promote exercise as a lifestyle choice, as an ongoing part of your life, rather than a kind of a quick fix solution to anything. And we focus on referring them onwards to other services that they can access to do exercise independently, and equipping them with knowledge for exercise, why it's important, and how to do it effectively. We also accept referrals from a variety of HIV specialists, so it can be consultants, it can be psychiatric liaison people, dietitians, it can be other physios. And the people that are referred to us generally have these conditions. So increased cardiovascular risk, lipodystrophy, which is often found in patients with HIV. It's a change in the shape of the person's body. So basically they become rounder around the abdomen, so they get an increase in the visceral and abdominal fat and a reduction in the functional fat, so around their faces and limbs. People with high or low body mass indexes, and I think through our experience so far, it's mostly on the higher range rather than the lower range. And reduced bone density, because we know that weight-bearing exercise is important to help build that up again. deconditioning, so either after kind of an acute illness or a hospital stay, or just generally not really doing very much, and low mood, because exercise is very important for addressing things like low mood and depression. And I'm going to now hand you over to Rebecca, who's going to go through the actual study that was run.
Great, thanks so much, Carrie. Okay, so I'm talking to you today as a physio who is very much part of the data collection and overseeing the actual gym group, but I was only one small part of a much bigger team. I feel like I need to first point out Andrea Petróczi. She's the main person for this study. She's the Professor of Public Health at Kingston University. Professor Declan Norton, he's also very pivotal to the study. He's involved in the biomolecular sciences at Kingston University. And then there's Gareth Jones, who's my boss, the physiotherapy team lead for rehabilitation at Guy's and St Thomas's. I also need to mention Kim Hawkins, who's my predecessor. She's now working in Australia, and Thomas, who's one of the postdocs who's involved in all of the number crunching and all of the analysis process, and he's been pivotal to the study too. So this study is looking at adherence to exercise, and we are focusing only on adherence to exercise in people who are living with HIV. However, a lot of what I will be talking to you about, you may think transfers to other patient populations as well. So before I even start, I want to just say, talk about what actually adherence is, because there are different words which are bandied around when people are discussing adherence. If I just say to you, I recommend that you come to a 10-week program of exercise twice per week. The associated terminology, compliance is a word that you've probably heard many times before, and what that basically means is that if somebody is compliant, the patient follows the physiotherapists or the doctors or the pharmacist, whoever's providing the guidance. The person who is the recipient, and in this case it's the patient, would follow those recommendations. What this term assumes is a paternalistic relationship between the advice giver and the advice receiver. And so if somebody is non-compliant, you often hear people saying, they're non-compliant with their medication, or no, they're non-compliant with their exercises, and essentially that means they're naughty. This term is essentially being phased out, and we don't use that term at all in clinical practice very much anymore. The much more relevant and much more important term is adherence, and this is more focused on the patient's choice to follow the decisions of their advisors, and in this case it's the physiotherapist. The focus is placed on the active decision made by the patient to do the behaviour, or to continue or discontinue doing that particular behaviour. So please bear that in mind, that what we're talking about here is adherence, as this is the pertinent term for the project. Okay, so I don't really know who it is that's listening to this webinar today. I don't know if anybody's from a physio background, or if anybody works with patients who are in gyms. I presume it's a lot of physios. But what we found with our population of patients who are living with HIV is that when people are invited to come to exercise, some people love it and others don't at all. Some people don't even come to their first session when we've invited them to it. Some people attend their sessions, all of their sessions, and others just don't. Some people start off really motivated and often trail off, and I'm sure that there's a lot of you thinking, yeah, that's probably me as well, actually. But what we did find for this group of patients is that adherence often falls below what is recommended. So if we offer 20 sessions, a lot of the time people were coming less than 10, and we wanted to know why. We also want to know who is more likely to be non-adherent, and we also, to go on further from that, is we want to know if certain factors predict adherence behaviours, so that ultimately we can develop targeted intervention strategies and optimise adherence or attendance for everybody. Okay, so before I talk about the study, the main study that we're going to go on to in a minute, this is the study which precedes the current study. It's part of a much bigger project, and we are only stage 2. But the first stage was essentially an observational study. So The team, which involved Andrea Petróczi and Declan Norton, my predecessor Kim, Gareth and Thomas, they did an observational study where they just observed the people who were referred in, and people were consecutively referred in either from the clinicians or from various practices, and they were referred into the group, and they just monitored them, so looked at what the characteristics were of people coming through, and whether they were likely to, whether they came to their appointments or not. And the aim of it was to identify characteristics which would influence the adherence behaviours to prescribed exercise for people who are living with HIV. What they found is that age, gender, baseline CD4 count, so basically how well somebody was, their baseline fitness level, the reason for referral, and they found that none of those factors influenced, differentiated people who were adherent from people who were non-adherent in the groups. However, perceived well-being certainly did. So people who felt despondent, felt like life wasn't really worth living, and that was measured through a questionnaire, they were much more likely to not come to their sessions, whereas people who felt very positive, that they were already doing very well, they were much more likely to come along. And perceived well-being explained more than 55% of the variances in attendance. Another thing which influenced whether people came along to their sessions or not was ethnicity. So we found that people who were white British often came to a lot more of their sessions than people who were sub-Saharan African born. So what we wanted to work out from that was, okay, why? So the conclusions from that study were that perceived well-being appears to differentiate between adherent and non-adherent people living with HIV, and ethnicity may play an influential role. So there may be some psychological factors and some socioeconomic factors which may cause barriers, which may influence whether people want to come along to their sessions or not. And so that was the recommendation of the previous study. Okay, so to take you on to where we are now, the aim of this study is exactly what was recommended from the previous one, to investigate psychological and socio-economic factors that lead to adherence or non-adherence to exercise programs and medical treatment in people who are living with HIV. And I just want to draw your attention to the fact that it's both exercise programs and medical treatment, because both are very important, and we just wanted to see how these thoughts, patterns and behaviours intertwine for both of the really important factors here. Okay, so the theoretical underpinning of the study, there's a few different theories which were used or were put into the model which underpinned what we're doing. The main one is the theory of planned behaviour. And with the theory of planned behaviour, if you're not already aware of it, the greatest predictor of somebody doing a particular behaviour, be that exercise, taking medication, or even smoking, is their intention to do it. And whether the intention to do it is based on what the people around them think, so the social norms, their self-efficacy, so how in control they feel, including their perceived locus of control, and also anticipated regret. When we then talk about intention, there's intention to do a particular behaviour, and there may be intention towards the goal of the treatment or towards the behaviour itself, and I'll talk about that in a minute. So those are two other theories which involve the control theory and the self-regulation theory, and then also personality factors, so conscientiousness, impulsiveness, and self-efficacy and self-esteem. And we collected all this data through questionnaires and computer-based tests, and I'll go on to that again in a minute. Okay, so I mentioned goals and behaviours and what was important there. So if we look at exercise, the goal with exercise, for someone to come along to do their exercise sessions, is essentially being fit and having a good physical condition. And behaviour is attending their exercise sessions and following the guidance of their physiotherapist. For medication adherence, the goal is having a good health condition, and the behaviour is taking their antiretroviral medication or their heart consistently, or following the doctor's orders. And all of these things come together in this quite nice diagram. So if you look at the three squares at the bottom of the diagram, the one which says attitude, subjective norms, outcome expectations and anticipated regret. Those are all pulled together from the theory of planned behaviour. And then the intention to do a particular behaviour is divided into the goal intention, so physical fitness or about the health condition, or the actual behaviour itself. And those are all the things which feed in together alongside self-efficacy, belief, self-regulation and personality to form a person's adherence behaviour. So from this point forth on the slides, you'll see some statements in navy blue, which are followed by statements in red. So essentially, I'm trying to make this as clear as possible for people. So the navy statements are those which have been pulled directly from the academic papers, and the red statements are explaining the scientific statement in something which is a little bit more like plain English. So essentially, this is our hypothesis slide. So the scientific explanation of the hypothesis, the relationship between adherence to exercise and medical treatment is stronger amongst those with a more favourable view of the goal. So what that means in plain English, people who are living with HIV are more likely to be adherent to their medication or to their exercise if they want to be fit and healthy, and that if they think that that particular behaviour, taking the medication or doing the exercise, will take them there. The second hypothesis, the way people think about the underlying goal of the treatment, explains their adherence behaviours over and above the behaviour-specific thinking. So, again, in plain English, being fit or healthy is more important to people who are living with HIV than the thoughts that they have about doing exercise or taking medication, so whether or not they like them or not. So I hope that makes sense. So we'll go on to the methods for this study now. The outcome measures for this study, the primary outcome measures were pulling together people's beliefs about taking medication, about doing exercise, and these things were collected through questionnaires and computer-based tests. So the questionnaires fulfilled the explicit beliefs, and the computer-based tests fulfilled the implicit and explicit beliefs, and I'll go into that in a lot more detail on the next slide. The secondary outcome measures are the outcome measures which we take with everybody coming through the group as standard anyway. So the FAHI might be something that you've come across before, which is a disease-specific, so an HIV-specific perceived quality of life outcome measure, which has essentially 5 domains. We also took anthropometrics, so circumferential measurements at the chest, at the hips, and at the waist, to look at microdystrophy and body fat distribution, as well as weight and height. Those being the ones we're doing the group skills yet. And then we looked at weights that people could lift, so you did the 1 rep max test, which is looking at strengthening the major muscle groups. And we do an endurance test, so a 6-minute walk test, to see how far people can walk, and we repeat that. We do that at baseline and repeat that upon completion of the group. Within this study, I'm only going to focus on the primary outcome measures, and I'll allude a little bit to the disease-specific quality of life outcome measure, the FAHI, when we go on to the results in a little bit. The rest of them we're not going to touch on today. So on the previous slide, I touched on explicit versus implicit beliefs, and this isn't normal terminology, and it certainly wasn't my normal terminology, which before I got involved in this study. So just to make it really clear for you guys, explicit beliefs are your conscious beliefs, and these are the types of beliefs that you're happy to share. So if you were to fill out a questionnaire, or if someone was to ask you how you feel about something, then there is what you're happy and what you want to share with somebody. Your implicit beliefs are often subconscious, and sometimes you suppress them because of the environment you're in, and because you don't know how people are going to react to you. So an example, if someone was to ask whether you think attending your exercise sessions is worthwhile, to the physiotherapist, you might say, oh yes, I think it's brilliant, I love it, I wouldn't ever want to stop coming to my exercise sessions. However, subconsciously, you may be thinking, yeah, but I don't really like the fact that I get quite sweaty with it. So you're thinking about other things around it, and these are the subconscious thoughts which aren't often shared. Equally, taking medication. So people may, to their doctors who are investing in them and supporting them, and they're giving them, in the UK, giving them the antiretroviral medication for free, they may not share that they have some actually negative beliefs around their medication explicitly. However, if we can tap into their implicit beliefs, what's subconscious, then we might get a more full and realistic picture. So let me just show you how we're collecting this data. So this is a sample from one of the questionnaires, and this is looking at the behaviours, so people's thoughts about doing the particular behaviours. And it's a this one is a 6-point Likert scale from strongly disagree to strongly agree. And statements are made about whether taking medication is important. I'll let you read them for just a couple of seconds, but these are the beliefs related to the behaviour. Okay, and then on the next slide, this is a questionnaire which is looking at people's beliefs towards the goal. And so this is slightly different. It's a 5-point Likert scale, and it goes from not at all sure through to very sure. And if you look at the statements that people had to make a decision about how they felt about things, then you'll see that this is looking more at their goal of treatment. So I guess right now you're thinking, how did you tap into these implicit beliefs that people don't want to share? So we're going to go on to this bit now, which is the computer-based test, which is this is how we started to get an idea of what people thought. So well, let's just take it to a real-world example and outside of the study for just a second. Imagine you're using a computer and you've got 2 keys. One key indicates whether you agree with something or you believe that statement is true, and you've got a second key which says you disagree and that you don't think something's true. So for me, if on the computer screen something was to flash up which says, do you like chocolate, I would instantly tap the I agree button, because I love chocolate. Chocolate is amazing. I wish it didn't make me so fat, but I love chocolate, so I answer very quickly. If someone asked me, do I like my job, I would still answer in the same way. I would still answer that I agree that I like my job, but I don't like the early mornings. There are certain things about my job that I would consider before I answered the same, yes, I do like my job, I agree, I like my job. So that time difference gives you an awareness that someone's thinking about it a bit more. And this is how they try and differentiate what is their intrinsic implicit beliefs. So then if we take it back to the research study and talk about exercise, so do you think exercise is worthwhile? And that person has exactly that set up for a computer, and they're told to click one key for they do agree with it and one key for they don't agree with it. Then the time they take to answer those questions in comparison to themselves with other questions will give us an indication as what things they're thinking about more, and so are giving us an idea about their implicit beliefs. Strength of belief. Okay, so inclusion criteria for the trial. They had to fulfill the criteria for the gym group, and in the NHS, and I don't know what the services are like across the world, but we do struggle with resources and finances, and so we can't give people open-ended ongoing exercise for life. So we have to give short bursts. With our patients, so we can't invite everybody just to come along because they have access to it. They've got to have a reason. So they had to have a reason for coming to the gym group. Though realistically, if you think back, people who've got high or low BMI or a bit deconditioned or increased cardiovascular risk, then people fit, or mood, people fitted the criteria quite easily. They had to be on their antiretroviral medication, obviously because we were looking at adherence beliefs and towards taking their medication as much as towards doing their exercise. They needed to be an adult up to the age of 55. They had to have sufficient cognition and understanding of English, obviously because the computer-based tests and the questionnaires were quite demanding, so they needed to understand. So we had a screening questionnaire to make sure we were aware that they did understand what's going on. And sufficient head hair. You might think that's a little bit odd, but one of our objective markers, the objective marker for taking medication, was that we took a small hair sample and we analysed it to the antiretroviral medication, and so we needed to have some hair. I was going to say I was happy to take hair from the head. At a push, I would go to the armpit, but I wouldn't go anywhere else. Okay, so this is the trial pathway. So people referred for exercise to us as they were normally through clinic, and they were screened by the physiotherapist, who was me, to see how they were most suitable to do the exercise. Was it that they were suitable to come to our gym program, or was it that they were working during the day, and unfortunately our gym sessions were in the middle of the day, so it did tease off people who were unable to either get here in their lunch hour or weren't working at those times or on those days. It may be at that point people were more appropriate to go to a Zumba class in the community or to go jogging with friends, but if they were suitable to come to the gym, then everybody was screened to be part of the trial. They were screened, and if they consented to be part of the trial and they were suitable, then we would take baseline outcome measures from them at the start of what would be their 10-week period. At this point, I was very, very clear to make sure that people were aware that they shouldn't change their behaviour towards coming to the exercise sessions based on the fact that they were in the trial. We wanted to get their true adherence behaviours and not a skewed attendance pattern because they thought it was important. And I think that this was really important to say that with our participants, they were paid in vouchers to come to their outcome measurement sessions. So on the first session, they were given a voucher. Upon completion of the 10-week program, they were given a voucher, and 10 weeks further down the line, they were given a voucher too, so that we could get the measures, even if people didn't want to come to the gym program. So it was very clear that they had to come as they would do normally. And then upon completion of that 10-week program, if I hadn't seen them at all, I'd call them and say, can you come in and do your outcome measures? And then they would organise a time for them to just come in specifically for that. And then everybody at that point was referred on for some form of ongoing exercises. And then they were brought back in for their final outcome measurement session. I'm getting a bit of a dry throat, thank you. So the novel aspects of this trial, the outcome measurements are collected whether or not the participant attends their available exercise sessions. And if you have looked into any research about adherence before, you see that often it's skewed towards the people who attend, because ultimately they're the people who turn up and give us your measures at the end. So this study was quite exciting that we were able to pay the participants to be in the study so that they would still come in and give us our outcome measures even if they weren't too pushed on the exercise regime. Another thing, the project assesses beliefs about the underlying goal and specific behaviours, and the beliefs and the adherence markers are united. So we would ask them these questions, find out exactly what's going on with what their thoughts are, and if their thoughts change. The questionnaires were given to them at each of the 3 points. And we also collected objective markers. So for exercise, our objective marker was the number of sessions that they attended out of the potential 20. And we also asked them within the body of the questionnaire to self-report, and we also asked them to complete an exercise diary. The medication adherence was objectively measured by this hair sample analysis. I'll talk to you again about this on the next slide. And the subjective marker was their self-report. So again, they would explain on the actual study. They would explain in the actual questionnaire that whether they had or not been taking their medication as was recommended. So this is the slide which, at the bottom it there's the link and the DOI link to the paper which outlines how we did this liquid chromatography. It wasn't me, it was away in the labs, which is where Declan Norton and his team were very much the forefront runners in it. So this is, we dissolved the hair and then centrifuged it and pulled out essentially what was the antiretroviral medication. It's a little bit like doping in professional sports and how they test for doping in those kind of ways. And it was quite sensitive, and it has been repeated. If you want to have a look at it a little bit more, then go and find this article. So this is the study, and this is our study pathway. So 94 people were screened, 39 were unsuitable. 55 were suitable, but 12 declined for reasons like they were unable to potentially commit to coming to the sessions, or they just didn't want to be part of the study. I didn't always ask them why they declined. If that was their choice, then that was fine. We just carried on. The 43 who were recruited, 4 dropped out after the first assessment session, or between the first assessment session and the second assessment session. There's one incomplete data set, and that's my fault. It was my error. I gave someone the baseline set of questionnaires the second time, so unfortunately we only have 38 completed sets of data with measurements from each of the accurate measurements from each of the 3 measurement points. So the sample characteristics. The age, they're about 44 years old with a standard deviation of 6.5 years, a range of 32 to 55 years old. About 65% were male, and just naturally it's split into low, medium and high attendance groups, and I'll show you on the next slide. So the low attendance group was between 0 and 6, the medium attendance group was between 7 and 12 sessions that they attended, and the high attendance group was between 14 and 20. And you can see that we cover all the bases, so we have got some information from people who came to no sessions or just to 1 or 2 sessions, as much as we have got people who are up into the high end of the spectrum, which was great. We had approximately equal split between our 2 higher prevalence groups in our area, so MSM, so that's men who have sex with men, or people from sub-Saharan African or sub-Saharan African born or from sub-Saharan African descent. So we also found, which is important, no age or gender differences between each of the 3 attendance groups. So this is the exciting bit. This is what we've found. I hope I haven't lost you so far with all of this, but if you want to zone back in now, this is the important stuff. There's a huge amount of data which we collected, and that's, yeah, it took about an hour to complete the questionnaires and to do the computer-based tests. In some cases it went a little bit longer. So there's an awful lot that people are answering. So this is only a small amount of the findings, and we're particularly focusing on exercise adherence rather than the medication adherence here, partly because of the audience, but partly because that's what I've been sent back. So the results in the context of this study. Again, I've gone for the navy blue being the scientific statement, and red is the English summary, but with a caveat. Yeah, exactly. So yeah, so gender has a significant influence on the efficacy to follow orders. Essentially, men are less happy to be told what to do than women. Age has a significant influence on the efficacy to follow orders. As people get older, they're less happy to be told what to do. And this definitely needs to be taken with a caveat, because remember that in this study, the upper age limit was 55 years old. So this isn't older, or up into senior age group. This is people just still within middle age. Age has a significant influence on the attitudes towards exercise. So within this study, as people get older, and remember just the same caveat, they're less interested in exercise than the people who are younger in this study. And again, this is a personality characteristic. So conscientiousness is a personality trait, links exercise self-efficacy with exercise adherence. So it strengthens the relationship between both the explicit and implicit beliefs about self-efficacy and adherence. So what that means in plain English, or as close to plain English as I could with that statement, people who say that they are conscientious have more positive beliefs about exercise and taking medication, and seem to believe that their behaviours would change their future health outcomes. This is going back to the perceived quality of life outcome measures. So I remember at the start this one of the secondary outcome measures, and this is changes in their perceived quality of life over time and their beliefs over time during the intervention period. So at baseline, perceived holistic quality of life did not correlate with the strength of associations regarding taking medication and exercise. So before people started the gym program, their quality of life did not link with their conscious and subconscious beliefs about taking medication or doing exercise. Whereas at completion of the course, the implicit associations regarding taking medication and exercise correlated significantly with the perceived well-being. So at the end of the course, the people living with HIV's quality of life did link with their subconscious beliefs for taking medication and exercise, so their beliefs are amenable. At 10 weeks follow-up, the correlations for implicit beliefs with quality of life regarding medication remain high, but interestingly not for exercise. So when people were discharged from the gym groups and were no longer under the supervision of the physiotherapy team, so that they were exercising on their own or they were going to a local gym, their strong beliefs about exercise, the importance of exercise, diminished. However, with exercise, it still stayed high. Also, interestingly, in the low, medium and high attendance groups, the quality of life improved over time. So everybody in the study seemed to feel better over time. The implicit strength of belief predicted their exercise behaviour better than their explicit self-reports. So the information that we were getting from the computer-based test where people were taking however long it took for them to answer each question, that information was really, really vital in giving us a much truer representation of what they were doing. So this is the final few slides. This is what a few of the potential reasons for not doing exercise that people were given options to tick whether they or not they were important to them. So they were separated out into belief-based reasons for not doing exercise, internalised justifications for non-attendance related to exercise itself, physical barriers independent of exercise, and external reasons independent of exercise. So the belief-based reasons, it may be that they disagreed with reasons for exercising, they felt exercise was pointless, they didn't feel the desired effect of exercise. Whereas the internalised justifications included they don't like the gym, they felt embarrassed or uncomfortable in gym clothes, or they felt it was an alien environment. For the physical barriers independent of exercise, that may be that people just generally felt unwell, overwhelmed or depressed, felt they were too ill or sick to do exercise, or were injured. And the external reasons independent of exercise, people were away from home, busy with other things, they had other commitments with their family or work, they forgot, or they had personal problems. So this is a slide which is essentially a snapshot of people at the end of the programme, so at the end of the 10 weeks, and looking at the reasons people in the trial gave for not attending their exercise sessions. And it's separated into the high, the medium and the low adherence groups. So remember with the high attendance groups it's from 14 to 20, medium it's 6 to 13 and low it's below 6. So you see in the high attendance group that the participants gave less reasons for not attending their sessions than the medium and the low attendance group. So that kind of makes sense. Now, if we look at the reasons given for not attending their exercise sessions, participants in the high attendance group did not report belief-based reasons for non-attendance. Rather, it was the physical barriers or the external barriers, so feeling sick, overwhelmed, depressed, or having an injury, or they were busy with other things, they had family commitments, personal problems, or they simply forgot. In the medium and low attendance group, they look more similar, with belief-based reasons for non-attendance, so disagreeing with the reasons for exercise, feeling the exercise is pointless, and not feeling the desired effects of exercise, alongside the internalised justification, so they don't like the gym really, they're embarrassed, they feel uncomfortable in gym clothes, etc. They also creep in as the reasons which prevent people from coming along. Statistically, the only significant difference between the three groups was for external reasons, i.e. the purple line on this graph. However, there was a trend towards significance in the physical reasons, and the wider team, the professors up at Kingston, feel that this is worth further exploration in a study with larger numbers, as they feel that the small sample size may have impacted on this result. Also, this isn't shown on this graph, so forget about this graph for a minute. The second follow-up, the changes which the changes in the differences between the different groups which were found at the completion of the 10-week programme, and the beliefs had checked for people where they had changed. They had actually changed back to normal or changed back towards normal when they weren't involved in the group intervention, and that's another thing here about the contact with the clinicians. And also, even in the high attendance groups, the people that came along to the exercise sessions the most, the belief-based reasons, internalized justifications, and physical barriers and external reasons, so all of the potential reasons for people not doing exercise, creeped up as we went from baseline to the follow-up immediately after what is the exercise intervention, and then 10 weeks following up down the line. So I think it's really important to remember that we can't expect that if someone is initially adherent, then essentially they will remain adherent, and they may need periodically to touch base with the specialist to challenge any unhelpful beliefs that they've crept in, but also to make sure that they're staying on track. So that's where we are now, and what next? So the current trial, we've still got a lot more data analysis to do, which is what I kind of alluded to a minute ago. And once we have analysed everything, we can draw some more formalised conclusions. And obviously, situations like this are perfect, so sharing the knowledge where we can. So again, I just want to say thank you for inviting us to do this. The long-term goals, obviously the next stage is determined on what we find from this data set, so it's going to be determined by the full data analysis. We want to identify the beliefs which influence intention to exercise or take medication in HIV. And I believe that from what I've shown you today, we're starting to get there, but there's still a lot more to come in. I mean, as I said at the very start, the long-term aim is to develop interventions which aim to modify beliefs responsible for poor adherence patterns and behaviours. So I guess it's the best way to summarise this is how this can influence future practice, and I'll give you my thoughts, and then if anybody wants to jump in and discuss this, because we're coming towards the final part of the discussion now. Currently we're still analysing the data, so there's certainly no concrete guidance yet, but hopefully this last, gosh, it's 50 minutes, has hopefully been food for thought about the factors which would influence adherence for the people who are living with HIV. Having an awareness, I think it's really important as clinicians to have an awareness of the wider context of people's lives, and I know that in the NHS, I'm sure with other healthcare systems, time is of the essence, and we need to try and measure what we're doing as much as we can do and keep people in, but ultimately physiotherapy is important, but there are a lot of other external factors, so the way we deliver our input maybe needs to reflect that, and we need to adapt around it so that people are getting the right support. It also seems to confirm the importance of tailoring guidance and programs to the individual and taking gender and age into account. So when you're working with your patients, then yeah, just keeping those things in mind too. So I'll finish off by just giving you a visual of the papers that have been published so far, and I don't think that's the end of this study. We certainly need to get a lot more out there. And then finally, any questions? And these are Carrie's and my email addresses. If anybody wants to be in contact at any point, then please do. We're happy to hear from you. Okay. So, where do we go to? Jackie? Hi.
Yes, I'm here. Thank you so much. Wonderful. There was so much good information. I have all kinds of questions, but I want to open it up to the other attendees. If you have a question, you can either ask it by turning your microphone on, or else if you slide your arrow all the way to the top of the screen, you'll see a chat room that you can type your answer in. So if you have a microphone that's not working, or you don't have a microphone, or for some reason we can't hear you, you can also type something into the chat room. So I will be quiet here, and if someone else would like to ask a question, please do so.
Hello? Hi, Susan.
Yeah, okay, hello. Yeah, this is Nina.
Hi, Nina.
Yeah. Rebecca, I'm sure you've been getting my email. So
Nina,
excited to be part of this work. Thank you so much.
Oh, no problem. Nina, I can't hear you very well from your microphone.
Hello, can you hear me now?
Oh, that's perfect.
Can you hear me?
Much better.
Okay. All right.
Would you
Thank
like to
you.
repeat your answer?
Hello?
Hello?
Yeah, I didn't hear your question. Do you say something? Hello?
Yeah. Nina, I'm really sorry. I don't think we're getting a very good connection here. So I wonder if you wouldn't mind typing it. Do you know how to do that?
Okay, yes. All right.
Yeah, maybe type it on your chat, and then then hopefully you'll be able to answer you a bit more easily. Yeah. In the meantime, while Nina's typing that, we have got what looks like a hand raised from Joseph. Do you maybe want to ask your question now, Joseph? No? Okay. Oh, hi. Hello, Joseph. Hello?
I'm going to do something to
I don't think we're doing very well with the sound, I'm afraid. Yeah, I'm really sorry about this. It doesn't seem to be coming through quite well. Joseph, would you mind also typing on the chat function, just so that we can hear you, because it's a very echoey line, and yeah.
Can't really make out what you're saying.
Can't really, yeah. Sorry about that.
There are some questions in the chat line. Ann Newstead says she'd like to hear she's interested in how to motivate people of all ages with HIV or cancer.
question.
Okay, Joseph, go ahead. I think we almost might be better going through the chat.
We can't think. Maybe if you just go all participants, maybe.
Okay.
Yeah, we're not even getting the chat through. Oh, there we go.
We've got one.
There's some sort of stigma concerning HIV and AIDS. Do you think this can also be a factor on adherence? Yeah, I do. I very much do, because I think that people, it depends on the individual. Some people who are living with HIV in the UK are very much, they're happy to share their diagnosis with other people, and when they come to the group are very much wanting to talk to other people, but others are less happy to do that, and they feel very much they hide away, but sometimes actually coming into the group can be really helpful and can support people with it. And I think it's our responsibility as the clinicians to make sure that we're supporting people about the reasons why it's important, and to try and banish any of the beliefs which stop them wanting to come and be part of the program.
At the moment in the group, we have 2 ladies who haven't told their families or friends of their diagnosis at all, but they are so excited coming to the group to talk to other people who are in a similar situation. So I think it can be a really good forum for not just the exercise benefits, but also the social well-being.
Yeah, true. Okay. But yeah, I think it is really important. I think there's a massive, trying to banish the stigma and to try and reduce down the stigma is another massive issue that goes way beyond the exercise interventions. I'm going to go on to the next point from Anne, and about the idea about how to motivate people of all ages with cancer or HIV to exercise. Yeah, I think it's really hard, and I think that from my own personal experience, I think it's really important to invest the time up front to find out what the motivators are for the individual. Although the study has shown that there are changes in the differences between men and women and people of different ages, I think we haven't got an idea of what you should do for people who are older, or an idea of what you should do for people of different genders just yet. So what I do from a clinical perspective is just make sure that you've just put the time in at the front just to work out what it is that people enjoy, because people are much more likely to do something that they enjoy rather than being told this is what you should be doing and having something which is more prescriptive in that way. So that's why I said earlier about people going to Zumba classes or going to exercise with their friends. If those are the kind of things which make people want to do exercise, and I think that you're much more likely to get people to do it and to stick at it if they're given that kind of environment. But also from the gym kind of perspective, if you can to create an atmosphere where it is still targeted towards them as much as anything else. And what would you say, Carrie? Is there anything else you'd add there?
I would agree with that, but it's also about finding the kind of self-efficacy and what's important to them. And it might be at what stage of the journey with the disease they are at. It might be that they actually just need a bit of time to understand what's going on with them. And if people are really scientific-based, you can go down the route of, we've got these articles that can prove to you that exercise is effective. You can have a look this way. You can go to expert patient forums where people can talk to other people who have been through it all before as well.
Great.
Hope that's kind of helpful.
Yeah, I'm just looking at the final point from Nina. So the point we're getting here, about if people's love for exercise diminishes with time, then probably supervised exercise could be the answer. Yeah, I agree. You also run a gym program in a university in Nigeria, teaching hospital. Great, okay, but you have no funds. Can you suggest ways to go ahead with what we do? Is that in essence to work out about funding, or is that to try and get a rolling program where people can come back in? Is that your question, Nina? Both. Yeah. Okay. So well, from a funding perspective, that might be something we'd need to talk to you about offline, because I don't really know what resources you may have available to you and how things work in the university. For us at the moment, although the NHS with HIV funding was ring fenced, so we were essentially protected, and we could kind of get away with doing what we wanted to do, and just letting people return to the program, but and just stay on a bit longer, because we are very much the believers that people having that contact with us and not feeling like they've been let out to go completely is really important, for people feeling like they can still continue and do some stuff outside, but then come back to us as well. In the clinical setting, a lot of what we're doing, HIV funding does not include physiotherapy services in Nigeria. Yeah, so that's really hard. So
I think one of the things we're finding here is that there's a lot more pressure on proof of evidence of what you're doing being effective before it gets funded.
Yeah.
So that's one of the things that hopefully research like this is going to help you maybe look at proposing something that's going to have an effect on long-term cost of HIV. So if someone is living better for longer, their incidental costs of hospitalization and other kind of more acute medical fees could be reduced. So if we can show some kind of cost-benefit ratio to having physio intervention, you might find that could be a way to get a bit more funding for your services.
Yeah, and then and I don't know about charity support, Nina. I don't know if there's any local charities that may want to divert some funding towards you guys. I don't know. I mean, the structure of our program is based on all of the evidence which preceded the two Cochrane reviews by Kelly O'Brien. So cardiovascular exercise for 20 minutes at 60 to 70% of the heart rate max. And that's what we're building up to in that environment. And then strength training of the major anti-gravity muscles. So quadriceps, hamstrings, we're doing bicep curls, triceps, lat pull down, chest press, and then doing some targeted abdomen, like Pilates exercises, sit-ups, those kind of things. Yeah, we can. I can send you some more details. If you get in contact with one of us, then we can send you on some of the papers that we use to structure the service.
I have just a quick comment in the few minutes that are left.
Yeah,
we
sure.
do have these listservs that are going up. So if you are a member of the listserv, or wait, what is it? Anne, can you remember what it is that we have to plug into? That's the online part that we're members of, that you can go to anyways, the listservs, you can go on and continue the conversation, and we'll be sending out information on that as to how people can join it. I'm missing the name of it. What's the name of it, Anne, that we're members of on the listserv? You have to have a certain type of a profile that allows you to link into it. Oh, it's LinkedIn. Oh, geez, I'm losing it. So anyways, we can actually continue this conversation. If you have a LinkedIn membership, you can go to the WCPT Oncology, HIV, Hospice and Palliative Care session, and you can have discussions with people in real time talking about some of these issues.
Okay.
One comment I wanted to, or one question I had is, in the U.S., sometimes we will go to find people where they're at, where they feel safe, and sometimes we'll go into the churches and conduct exercise training sessions for people who are at risk.
Yeah.
Is that something that's happening in the UK or in Nigeria?
So in the UK at the moment, the answer is no. I mean, what is generally happening? No. When people the wider public health and medication teams are going out to places where the higher risk group people generally tend to frequent. So, for example, people will go and do on-the-spot testing for HIV in the churches for people who are more from the more religious sub-Saharan African kind of communities, and also for places where men who have sex with men to go to sex saunas, or go to places where people may potentially go cruising. So we'll go there and do their on-the-spot testing. But generally, to do the exercise sessions, people are brought into the places where we've got the resources. So in the hospital, we've got a gym program running. Also at Chelsea and Westminster, Darren has got another program which is great, which is set up over there. And there's another one at Mildmay, and then there's another one which is at the YMCA. So essentially, it's bringing people into the places where we've got the resources at the moment. But
whether we could look at doing something now with technology that we could do kind of supervised webcam type stuff to get to people where they are if they don't want to be out of their house or be seen at a hospital situation.
Yeah, exactly. Yeah, and I think the other thing that we struggle with is that for HIV services, generally people are funded or employed. We're employed by guys in St Thomas's Hospital, so essentially we stay on site here, whereas the community services are quite distinct, and I think that that's really important, that we need to be linking up with our community colleagues and seeing what we can do around supporting them and what we can do from that perspective too.
Okay, well, I just want to thank you for this wonderful presentation, and as we close today, I want you, Carrie-Ann, and you, Rebecca Mullin, to know that we're going to be sending you the International IPT-HOPE Scholar Award to thank you for your presentation. And Nina Chegbo will be sending it out to you. It's an electronic device, but it's a token of our esteem and thanks for such a wonderful presentation. Anne did post the LinkedIn site, and then I did want to tell Joseph, we are recording this session, so you can download it from the WCPT oncology site. And
yeah, we didn't, unfortunately. But he has got our email account, so hopefully we can answer those questions directly.
Okay. All right, so that's all we have for this afternoon. Thank you so much, everyone who's attending and interested, and we'll try and keep this growing on our WCPT website. And Rebecca and Carrie-Ann, thank you so much. This was such great information. It's giving us more insight onto how to deal with patients with serious conditions. And what's really fun is that we get to share it to people around the world that are interested. So thank you kindly. Thank you so much.
Oh, no, pleasure, real pleasure. I'm lovely to meet you all.
All right, then I will be signing off. Thank you very much.
Thank you. Bye-bye.
Bye-bye.
Bye-bye. Okay.